So thank you very much for coming up. I hope to get you out of here less than an hour, but the only way you would enjoy this is to stop me and ask questions. I'm so passionate about this because I think in almost all of the research that I've done, two things have come together that has not come together for me in other research. Number one, the research question itself came from parents. Usually we sit in our high towers and come up with research questions, but this was parents saying, hey, what's all this about medication? So I'm really happy about that. Number two, when CAN FASD, so CAN FASD is the research network in Canada, looked at their visits to their website, the algorithm was number 2, and you see it here as the one that people reached out to and downloaded. So we're really kind of happy, kind of not happy, because we don't have all the evidence to say it is perfect, but then people are finding it useful. So for that reason, I'm a bit passionate on this topic of using psychotropic medications in FASD. Now, what I was put together in this PowerPoint is to describe how we developed the algorithm. And I was so happy somebody asked me, what's an algorithm? An algorithm is just a decision tree, right? If X plus Y occur, then Z is where you go. So that's essentially what an algorithm is. So I'm going to tell you how we developed it. I'm going to use an example, kind of made up example of a real life situation of a 17-year-old Tony to share how to use the algorithm. And then if we have time, if you don't engage me too much in the conversation, I'm going to bore you with the evaluation that we've started to do on the algorithm, okay? So like most of the setups, I have to kind of disclose if I have any conflict. During the development, we were supported by CAN FASD. And then during the dissemination and the meetings to bring the experts together, we got a funding from the Saskatchewan Research Foundation. So we got a little bit of funding, just to say, but they have nothing to do with the medications that I'm going to be speaking to you about. So I hope, by the way, Doug, I indicated, and maybe you have the best position. Feel free to just jump in, ask a question, raise your hand and interrupt me. I just described the way the presentation is. I'm going to describe how we did the algorithm, and then give an example of a 17-year-old, and then finally share the results of where we are to prove whether it's working or not. So while this is a youth justice conference, I included a little bit of youth justice involvement, not because medication is the primary thing. And you see that I'm also going to refer to some of the non-medication treatment. In fact, we had 12 experts develop this algorithm. Our number one priority was everybody that is going to jump into the medication should be properly equipped with the social and psychological interventions that would keep them healthy. So you see that I'll mention some of the treatments that are important. Okay, I also hope to help you understand just how to implement, and if you're able to join us in the evaluation, it's an international evaluation that we're having, so it's not only Canadian, and we have ethics for that. Always the first thing to do is just put it out there so that you see what the algorithm is. So picture this. You got an individual who has been diagnosed with FASD. The person may have additional mental health diagnosis or additional mental health symptoms. The person has been assessed by the Australian guideline or the Canadian guideline and identified the brain domains that are impaired. When we brought together the experts, what we saw evidence for in the literature was actually 4 clusters. We could not substantiate using all the brain domains like executive function, memory, cognition, attention to identify and label a medication. So we clustered the manifestations of FASD into 4 different ones. So from left to right, An individual has FASD, but is showing hypervigilance, is showing aggression, is showing irritability, is showing sleep problems, anger problems, tension, reduced pain. We cluster that into the hyperarousal cluster. And if the doctor and the team and the family say this hyperarousal cluster is present, we are advocating, number one, make sure that all the non-psychotropic interventions of psychology and social have been taken care of first. And then you go to the first line of treatment, which is a choice between clonidine or guanfacine. Remember, this person already has a diagnosis of FASD, but the way they are presenting, they have more of this hyperarousal cluster. You now move to the next one, which is the emotional regulation cluster. This is a person with FASD, but they manifest a lot of mood instability, irritability, excitability, anxiety, depression. And we then advocate, after you have ensured that the psychology, the social, and the support, and all of those things are in place, and there's still a need for intervention, then you go to the first line treatment, which is a mood stabilizer. And based on the literature, we suggested either using divalproate, many people call it sodium valproate, and is an anti-epileptic medication with good indication for mood disorder, or lamotrigine. The third cluster is the hyperactive and neurocognitive cluster, essentially the people with kind of more ADHD-ish type of behavior. And then the last cluster is the cognitive inflexibility. By the way, I can make these slides available, so feel free if you want them, I can definitely make them. So this is the way we conceptualized it, to say, once you know the person has a diagnosis and you see the prominence of one of those clusters, you start treatment there. And I'm going to show you how do you choose one cluster from the other, and what about if you have 2 or 3 or 4 or 5 clusters, whatever you have, what do you do? So let's jump into Tony. By the way, just I really want to engage some conversation. So anything strikes you here, anything makes sense, anything looks odd, anything looks, you know, kind of funny. Say that again? What age is Tony? Tony, 17. 17. I'm coming to that in a minute. Yeah, Tony is 17. No, okay, so I'm just going to give an example with Tony, who is 17, and you're going to use the algorithm and answer some of Millie's questions during that, by the way. But I'll just quickly say, you're absolutely right. And when you look at irritability, it can happen in the hyperarousal or in the mood instability. And so the question is, which one has more for you to select? And as I said, it's not one or, it could be one and. And then the next question is that which one of this is causing the worst impairment? And I'll give the example, okay? Wait, I have to interrupt you. I'm going to go, whoo-hoo, because I tried to get psychiatrists into the room. Nobody wants to listen to me, so. Absolutely. So there's an article, by the way, so there's an article on this. You got the article? So within the article, you see we are referring to them as prescribers. So right now is the family doctor, is the pediatrician, is the child psychiatrist, is the adult psychiatrist, is the forensic psychiatrist, is even the nurse practitioner in some places. So we don't have say to what the regulations are in different places. We just present what we think is in the science, and people, yeah. So the point there is that the use of medication in people under the age of 7 is a bit of a debatable one. And so, unfortunately, this is a very fascinating thing, Wendy. So most of the literature, please, some of you should just be patient with us. Most of the literature that we use, the medication was prescribed in people under the age of 7. But the panel felt that it was so controversial that we couldn't be making the recommendation, even though we have science to show that 7-year-olds are prescribed medication. In fact, one of the recommendations, or rather one of the points of evaluation that people talked about was, why are you using this powerful medication in young people? And as you know, for those of you who have gone to the American Psychiatric Association meeting, there's always a big protest against using medication in children. So we are sensitive to that, and we obviously want people to recognize that we are aware of the issues, but most of the research was actually done in those young people. Yes, Michael.
Just in addition to that question, the STARS only relate to cluster 4 medications, the risperidone, the olanzapine, the aripiprazole, and then the additional recommendations for an emerging field, or does it apply to everything on the first line, second line, and adjunct?
I know, just all the ones that have the star on it.
Beautiful, thank you.
Yes, yes.
Just wondering about the consideration of non-stimulant medications for the hyperactive group.
Yes.
Do you think of having another box below?
So, yeah, of course, there's atomoxetine, right? There's
Yeah,
atomoxetine.
I mean, clonidine up there, but...
Yeah, so if you look under the hyperactive, the second line is other stimulants like methylphenidate, and then the non-stimulants, atomoxetine and bupropion. The reason for that is that we actually had to combine, and I'll show you now, combine what was written in the literature with what our experiences were. So that's the reason why it is second line. We found out that actually the stimulant should be the first line, and there's actually some literature that suggests that methylphenidate is not as good in people with FASD compared to the amphetamine salts. So that's why we had lisdesamphetamine as our first choice. Yeah. Yes.
These should not be prescribed except in consultation with a paediatric psychiatrist.
Yeah.
Paediatric psychiatrists are very rare. In my area, they don't exist. And the medications were prescribed by the paediatrician. And some of them are restricted medications that they have to get permission for. But it was essential that the kids be prescribed.
Sure.
If we waited till we could find a paediatric psychiatrist, we would still be waiting.
Yeah.
Just to make a comment, some of the psychiatrists now in the major cities provide a sort of consultation service for paediatricians. So they ring them up and say, this is the situation, and they collectively...
may well have done that without
Right.
me being present.
Right.
Yeah.
That's correct. Yeah. And actually, so for example, in Canada, what we did, because of that consultation, we identified a number of experts on this panel to be available for such consultations. So good point. And services and capacity remains a big issue. By the way, I like this. I know I have lots of slides, but better that we answer the questions out of the way. So let's talk about Tony. So Tony is 17 years old, a product of a violent rape, adopted at birth due to a single mom's inability to care for him after she relapsed in using cannabis and alcohol during pregnancy. And you heard today that it's very likely that the cannabis use may accentuate certain disorders in people who are exposed to alcohol. So multiple exposures is a real thing. The mother smoked cigarettes during pregnancy, and Tony displayed early temper tantrums and aggressive behavior. So to the question, is this affect regulation? Is this hyperarousal because of trauma? Again, this is where we believe a comprehensive account by the family, by the clinician, and the details from function. Our goal in this algorithm is improving function. Whatever we do is about function. So Tony unfortunately assaulted his teacher and was suspended from school, and he was suspected, not diagnosed, suspected of having FASD with the additional diagnosis. I think somebody went through, was it Wendy, went through all the diagnoses today that people get. This is a discussion we psychiatrists have been having. I don't think it's a discussion that is going to end. So all kinds of things, ADHD, ODD, EDS, and panic disorder. Anyway, Tony was irritable. Again, you see where sleep and irritability comes in the hyperarousal, but aggression can happen in both, repeatedly and at times unpredictably aggressive to his foster siblings. At times when frustrated, again, inability to control his tolerance for frustration, he will bang his head on the wall, and he will be very intolerant to change, requiring an immediate response because he wants things to be done quickly. His strengths are that he's generous, he likes, is liked by his friends, and he's a great snowboarder. So that's Tony. Of course, not a lot of information. I'm sure there are many things you want to know about him. You know, what is his development? When did he achieve his milestones? Did the mom actually get diagnosed? And did he have whatever? But what happened is that we're talking about medication. And so this is the regime of medication that Tony is on. So you can see him is on a PRN of olanzapine at 17. He's on lisdexamfetamine at 30 milligrams. He's on aripiprazole, which we mentioned. He's on mirtazapine, melatonin for sleep, clonazepam 1 milligram daily. But I think what is captured here is that progress is poor. Remember, function is the main goal for this. He may be on this medication and be fine, and that's good. But if he is on it and there is no progress, then there's an issue there. Now, just out of the block, who can say, based on what you know about the algorithm of the emotional regulation problems, hyperarousal, hyperactivity, cognitive inflexibility, what would you say is likely the one causing the biggest problem in Tony? Hyperarousal? Anybody disagree? Right? He assaulted his teacher. He can't go back to school. He's suspended. Function in school is in trouble. He may be frustrated. He may have mood instability, but that yet hasn't gotten him. He may also be impulsive and all of those things, but he obviously attacked his teacher, right? And so this is, I know this is a brief case, but this is where the parents come in. The child assess is there so that you can make a determination on, if I don't repair this cluster, Tony is not going to function. There may be times whereby you may just wait for something to happen, because one of the reasons why parents came to us is that they wanted us to do something about polypharmacy. Polypharmacy is when an individual alone has multiple medications. So how do we do that is to get a system whereby you go step by step to be able to get the right medication. Now, before I tell you how to use the algorithm on Tony, you'll be mostly familiar about some of this information about misdiagnosis. So remember, Tony doesn't have a diagnosis. It's likely that he has FASD because of all the things that we're seeing, but there are multiple people who do not get diagnosed till very late. And this is a very well-known study where 80% of the people did not have a diagnosis before that FASD assessment, but had other diagnoses. And of course, we have talked about this in terms of, is there FASD in the mental health system? This is a big question. In fact, there is a psychiatrist who has written what I would call a scathing rebuke for the Canadian guidelines of FASD diagnosis. He is arguing that we're just opening the door to bad science, because really we should be diagnosing people with reactive attention disorder, ODD, rather than FASD. But that's a different conversation to have. But this is because there is doubt on whether psychiatrists are actually needing to learn about FASD. So you can see this result of going to a mental health hospital for young detained youth and getting a case ascertainment study, which is the topmost diagnostic process, like they did in Western Ontario, Western Australia, to get a diagnosis in 22% of the individuals sent there for assessment. We looked at an outpatient forensic clinic and got a 26% of people with full FASD. Now, they've been moving around and living their lives with other diagnoses. Nobody paid attention to the FASD, right? And then in a psychiatric hospital, 30% of the children in that hospital revealed the history of maternal alcohol consumption, 30% in a psychiatric hospital. So if we think that there is no FASD in mental health, we've been giving them these medications, and we need to kind of wake up and realize that they're coming through our offices, and we need to recognize that. Yes?
Why do you think the rate was so much higher in the Saskatoon cohort than your...
Yeah. Very good question. So they were 46%. So the 46% was a study that was done in a biased population. Why is it biased? So it's 207 bed hospital with people who come in there from a forensic lens. They've been sentenced to jail. So they've got mental disorder, substance use, as well as criminality. And if you know all the factors that are secondary disabilities, is already biased. Now, the sampling wasn't biased, but the population is biased. The sampling was, if you have a release date in the next year, you're going to join these people. And actually, majority of them agreed. I think we had 1 or 2 people decline. Now, you can argue that people who are being released have a particular characteristic, maybe they're better, but that's the reason. I think it's just sloped towards those people who would have FASD because they got substance use, they got addiction, they got criminality, they got mental, because that's what the hospital is for. So that's why we have a high rate there. And by the way, there is a study that was done in another forensic hospital using their medical chart to do a diagnosis, and they got close to 27% as well. And that's just using, not a clinical, we did a clinical diagnosis, they just went through the records. So my message is, if you're a mental health professional, it's very likely 30% of the patients that you're seeing will either be diagnosed with FASD or are likely to have FASD even if you don't know it. The good thing is that I just want to share this study that showed an improvement in the knowledge of mental health professionals, which is a good thing because then we can be aware, identify, screen, or at least red flag them up to have a diagnosis. I won't go through this system, but again, it's just recognizing the fact that our youth and adults in the criminal justice system intersect with different places because of their disability, whether because of memories that they can't remember, so they fault their condition, whether because of the fact that they have hypersensitive skin and they get into a conflict with the police, whether because they are taken advantage of in jail, whether because they are comfortable. So the whole cycle intersects with those qualities and deficits that we have in FASD. And I shared this earlier on, so the rates are obviously high in youth. Yes?
Say, our teenager had what I would call a mental health breakdown. He had an episode where he couldn't cope with the stimulation that he had, and he became violent and aggressive, and he's a fight or flight, so he did his fighting and then he did flu. Anyway, he ended up in hospital, and he ended up...
Can you describe the...
Like?
Just so that
okay. He ended up being assessed by the mental health unit in the hospital, but they said, no, he doesn't have a mental health issue, so he doesn't come under our care. And the physical people said, no, he's not sick, so he doesn't come under our care. And anything that can be done to get the mental health field to accept that people with FASD are actually experiencing mental health episodes is going to be useful.
Yeah. Thank you. And it's not an uncommon story. We did a barriers and enhancers study in our local area, and that came up whereby somebody would say, don't tell them you have FASD, because they are afraid that they're going to be told, well, we can't do anything about you. And there's a reason for that. You know, we are all trained as physicians to at least be able to make a treatment that will cure the condition. So the definition of treatment is changing, whereby you have to understand reduce harm, improvement in function, not essentially removing all the symptoms. So I think it's getting better. That's why I shared the fact that many years ago, there will be many people that would not see it as a relevant disorder, but now people are beginning to understand. Yes, Wendy? Oh,
I have a question about FASD and psychosis, the overlap, and how you would maybe treat that differently than a young person who didn't have FASD.
okay. So the algorithm, when we developed the algorithm, we looked at the literature. Dr. Susan Rich had done something around the cognitive inflexibility piece. So they tend to fall in our algorithm, most likely from the algorithm will fall on that cognitive inflexibility. Now, it doesn't fit in really nicely, right? So we looked at into the literature, and I'm going to mention that in a minute. It appears that the wiring of the brain, the disorders found in the frontal lobe, all of those put them at risk for developing psychosis. So we don't really have a place specifically for them in the algorithm. Now, I treat lots of people with psychosis in forensic practice. So I just follow the schizophrenia guideline, use antipsychotic. But I've tended, actually, if I know somebody has FASD, I've tended to lean closer to clozapine than anything else. And there's actually a literature on that. Yes?
Sorry, the second part of that question is, does psychosis look different in people with FASD versus...
That's a debate, Wendy, and I can tell you that Susan, who has done more work in it, and I kind of not clashed, but we kind of disagreed. I think that the manifestations of the psychosis is impaired by, one, the language that is used to describe it, and two, the type of delusions. I call them fantastic delusions. Like most of the people I've treated with FASD and delusions, you see a lot of what I call fantastic. So it's either they are kings, or whether they do these odd things that people don't do. They don't get a lot of paranoia, and it's really always, something moving in their body, something stuck somewhere, and those kind of things that are slightly bizarre in nature. So, yes. Sorry, Michael, let me just finish with, yeah. So, but Susan thinks the other way.
May I ask you about a case later then?
Say that again?
Without outing this person, I might ask you about a case later.
Oh, absolutely.
5 minutes later.
Absolutely.
I've got a really fascinating person who I thought they actually were developing a psychotic illness separate to their FASD.
Right.
And to me, it looked exactly like a young person who was psychotic. And the parent was saying, oh no, that's part of their FASD, that they've got these thoughts. And I'm like, no, this person's actually stepped over into psychosis. So,
right.
I come from a background as an adult psychiatrist as well, so that's my training.
Okay.
Yeah.
But Susan, the reason why I'm telling you this is that Susan is a child psychiatrist. So she actually agrees with the other person, saying, no, this is just, they haven't formulated a language, give them time. All they need is lamotrigine. So she actually treats a lot of people with lamotrigine, which appear to be psychotic. So we're still learning about that. Yes, Michael, thanks for your patience, by the way.
All good. I love that conversation and very interested. And at the risk of opening a can of worms or skipping to the end, I'm wondering if the challenge that you have in the psychiatric or in the mental health sector with FASD is the fact that the DSM-5 TR still doesn't have a set criteria. Second part of that question is, does these categories potentially lead more towards a better criteria that could be used in a diagnostic manual?
Unfortunately, to the second question, I don't think this is going to lead to a classification that is better than the DSM. The reason being that when I down in the presentation, you see that we aligned the medications we're recommending on two things. People reported on it in the literature, and secondly, what is the likely neurobiological basis for using the medication? So, for example, hyperarousal, we believe that the HPA axis is relevant in that context, but we can't use that for our symptomatic diagnosis. Now, there is a push right now in the psychiatric field to do what they call the domain-specific diagnosis. Now, it's many years ahead, and people have started looking at it, dividing it. Maybe that's where that would come in. Now, when you talk about sorry, I forgot your first question now.
The first part was around the section on
Oh, the DSM.
the DSM, where
Right,
it's
right.
otherwise specified diagnosis,
Right.
and there's not a set criteria because of the heterogeneity. I believe it's because of the neurological basis of
Yeah.
the presentation. But do you think that's why there's this kind of disconnect between the mental health field
And that, no.
and the diagnostic?
So we have looked at that. I think it's a multiple reasons. One is recall that mental disorders existed before FASD. So we had psychosis, Freud talked about it in the beginning of the century or whatever. But FASD only came in 72, 69, right? So many people had already been trained about it. That's number one. Number two is that we never really got treatment medication for FASD. So most psychiatrists did not embrace it. You have treatment for panic disorder, treatment for this. So it was really late. That's why we ended up looking in the literature. Do you know that there was a study in clinicaltrials.gov trying to evaluate the role of atomoxetine for 10 years? They could not finish that study. So we were waiting and waiting. There are only 2 randomized controlled trials in FASD with numbers of 12 people total. Anyway, not to beat down on the study, but to just tell you that we've had a problem in that we were not engaged in that field because there was no tool to use for a psychiatrist. The other thing which I think is probably pivotal to your question is that the DSM itself has been a confusing, on FASD, I love the DSM, don't get me wrong. So the DSM, interestingly, it has had what I call a love-hate relationship to FASD. In DSM-3, they put it there. They took it out in DSM-4. They took it out in DSM-4-TR. They brought it back in DSM-5. So this idea, and even in the DSM-5, you're still not sure. Is it in the neurodevelopmental unspecified, or should you use the research criteria for future studies? So all to say that the DSM hasn't been helpful, but I think it's getting there. I doubt if they're going to remove it. I think it has come to stay. I think you're going to see some research going through there, and it's very likely it's going to be incorporated. That's my view. I've attended the sessions that devised it. Unfortunately, the leader has died, James Harris, but I don't think it's going anywhere anymore. Yeah. Okay. So, medications, either you detest it, whether you depend on it, or sometimes people divert it. So we thought, well, why don't you see it differently? Let's do something different, right? So we brought, after we heard that parents were complaining about the role of medication in their loved ones, we brought a group of individuals. And what I like about this picture is the varied multidisciplinarity that is represented here. I always like to point out that there is a mom in the experts, so greatest point ever. We also have an algorithm developer, Dr. David Oza, who knows absolutely nothing about FASD. So it was one of these, you go to see the physiotherapist and then they shake you and you leave feeling sore, because David will say, where's the evidence? Where's the evidence? There is no evidence, David. No, you got to, because he's written a lot of things about algorithms. So we went through from 2016, pulled some experts together who were working in the field to say, look, we need to help answer this question. How do we reduce polypharmacy? How do we look at the evidence? What is exactly the evidence? So we actually did a systematic review at the time. There had one been done in 2009. I don't know if Lindsay was involved in that or not, but anyway, 2009 there was one. So we did one in 2018 to look at everything that has been written. So appalling that the whole literature from 1997 till 2018, there were only 324 people, period. Such a small number. And these only 2 randomized controlled trials. So we don't have the evidence. That's why anytime we speak about the algorithm, I put it up front. The evidence is not strong, but this is the best that we can come up with. So Tony, this is the algorithm, and the reason is that we need a decision-making process. Now, for Tony, the idea about hyperarousal is very true. So what we do with him is that, again, this is the step that I think is helpful for anybody who is using the algorithm. Remember, the person is fully diagnosed with FASD, so confirm the diagnosis. Now, unfortunately, in some places, the capacity, as Millie said, we may not have the diagnosis, and so the person needs help. You look at it. Number 2, establish the functional baseline. What are they functioning at this time? And how does that match the expectations of the person and the family? Then set your goals where you want to go. This is basic things that we all do, but we feel it's so important when it comes to medication that we need to be careful. So this is where your question is, Millie. How do you determine which cluster to go for first? Because we don't want you to treat 2 clusters at once. The reason is if you treat one cluster, and we all know this in psychiatry, if you treat one cluster, there is up to a 60 to 70% chance that the second cluster will improve on its own. So we see that in the treatment of people with bipolar disorder, with anxiety. If you treat it, ADHD and anxiety, if you treat with the stimulant, the anxiety will come down. So you don't have to treat both together initially anyway, but you may reach a point whereby you may need to add the other. So that's why we wanted determine the most impairing when it comes to function. And that's a decision that you, the clinician, will make with the family. Once you've made that decision, then you go for it. Ensure that the person has the psychological things. Yes?
Are those clusters written 1, 2, 3, 4 for a reason? Is there an order of them, or are they just...
Yeah.
Because to me, aggression is a really important...
I don't know. They're not. Yeah.
Okay.
Yeah. Good question, though. No, they're not. They're just, once you have the symptoms and you think they fulfill it, then you can go ahead. Yeah. So then you now go to the next step. We want prescribers to ensure that they do not upgrade prescription beyond other non-psychotropic medication interventions. And there are a number. Is the person got the teacher's aids that they need? Do they have a safe home to go to? Like, all of those things are important, or else you're pouring your medication to somewhere that is not going to be effective. Do they have someone to monitor the medication? Do they have a place that the medication is safe? We talked about diversion. I've treated people who would take their prescription, they're in the bus, somebody is waiting to receive it. So where is the medication going? And so then once you decided, then you go to the first line. Remember, there's a first line, a second line, and then the adjunct. The reason why we chose first line is that at least all the experts agreed that we have something in the literature that suggests that they've used guanfacine in hyperarousal, lisdexamfetamine for people with hyperactivity, risperidone, aripiprazole for people with cognitive inflexibility. That was the reason why they were top. And then the second line is an option after that. Now, the next thing is obviously the question that will be coming to your mind: what happens if it's not working? So again, this is based from experience, and the idea is that you want to start, like most learning disability places, you start low and move slowly, basing your increases on a risk-benefit ratio, not on a weight, not on regular dose, is on a risk-benefit ratio. And we put that very clearly. The benefits are better. You don't have to go to 20 milligrams of citalopram. If they are not, you can go to 40 milligrams, of course, monitoring everything that you need to monitor. And then if you spend 2 to 6 weeks, again, that's a long range, which is a 2, 3, 4, 5, we really want people to give it a good shot. And if you're not getting any improvement, then you can go to the second line. If there is some improvement, and we call it some improvement, we debated, is it 50% reduction, 60% improvement, Clinicians, they do what they do. I mean, if the function is improving and there's some improvement, then we encourage you to adjust the dose or even add the second line on top of that. Monitor for your second cluster once you started the first one. If the first one is improved and the second one still hasn't improved, and so Tony is still aggressive, Tony is still bouncing his head around, then you may consider something else. Now, the big question which I've been having is that what do you do when they're already on medication? And this is a very valid question, because that's why we still go back. What are the functional goals? What is the level of disruption right now? Which medication should you take out? And again, you follow the algorithm, you ask yourself, Tony has more problems in hyperarousal. He is on medication for hypercognitive, he's on medication for cognitive inflexibility. If we want to go back to basics, I'm going to start with those two and leave the other one. Basic stuff. So this is Tony, as we mentioned. We believe that his first issue is more on the hyperarousal, and then there's the emotional regulation problem, the hyperactivity. So we just go through that. Now, this is based on a case that we have dealt with. In the cases that you're dealing with, it may be possible that maybe actually the functioning problem may not be hyperarousal. Maybe that he's so hyperactive that he hit his teacher or whatever. So you have to make that determination as a clinical decision to be able to jump onto the medication that you're choosing. There are obviously some treatments that are important that we need to think about. I mentioned the issue of the psychological treatment, but also the safety of the medication. A lot of our patients are not safe with medications like stimulants. We need to protect them. I work in a jail. Having a stimulant prescribed is a risk factor for you being assaulted. So you have to be aware of all of those things that we need to be looking after. Again, this is just a reminder of some of the non-medication treatments that have evidence. Yes, Michael.
Sorry, I'm asking lots of questions, aren't I?
No.
With the the factors on the last slide, are there any tools to support observations for carers to get a shared language? Because it's very difficult to get clean data from a team of carers around a person with FASD.
Yeah, so we developed something. The challenge we are having was a little bit of a disarray between the panel. Once we developed the algorithm, it's an excuse, but I need to answer your question. Once we developed the algorithm, we were ready to publish it, COVID hit. So we couldn't go around and really stimulate people to get to use it and give us an opportunity to evaluate. So that question came up. So we actually developed how you can record some of the symptoms that will feed into one or two of the clusters and how you can monitor if they are improved. Not everybody agreed with it, so it's kind of stalled, unfortunately. So it's a bit of a challenge. So we just use a clinical environment. Yes, no, we really, because you're right? How do you know this is hyperarousal? Well, these are the symptoms we want you to monitor. Well, then how do you know it's improving? Well, this is reducing. So it was something that we really wanted to do. Many of you will be very aware of the role of mentoring for people with FASD, so not a big issue here. Again, I've mentioned the idea of how we use the medication, and also those that you're reducing, you reduce, hold and see, reduce, hold and see, then discontinue one, then move to the next one. And just to see how it aligns with the algorithm for those who already have medication on board. If it's new, just follow these steps that we have here. The last thing I would say about the use of medication is that, and this is a study we did on 2 adults with FASD. If you find something that works, do not adopt the normal system of reducing support because somebody is becoming independent. Things just fall apart. So keep things where they are. If you get the right medication, you've got your goals, please keep them where they are. So again, observe side effects. For some reason, people with FASD have some really unique side effects that has been reported in the literature. Ensure that there is a scheduling system for those who are taking it on their own. These strategies we always use, put it by your toothbrush, put it by your light lamp, and all of those things are more relevant and useful for people with FASD. And we got some feedback about why it treats young people with powerful medication. Then we found out that clozapine was used in 2 cases and with good outcomes. Then they asked us, well, I don't have time to be evaluating my patient. Can you develop an app? This is where, you know, physicians, they ask you for something, then you do it, and then they just look away from you, right? So we actually developed an app for this algorithm. So I'm going to share that with you. For those of you who are in the field, I know I only talked about psychotropic medication, but there's obviously some evidence around choline being used in people, especially younger children. So I'm just going to share with you some of the results in terms of what has happened to the algorithm since it got launched in 2020. But I'm wondering if there are any questions on how to use it, or rather how we got to it, what it looks like, and then how to use it practically. Is the hand going up? Oh, okay.
There seems to be a resistance from some families to medicate children, full stop. I'm finding that increasingly. Have you found that problem, and how do you deal with it?
You know, that's maybe it's just maybe the field that I am in. I found it that people are actually willing to engage with it for some reason. I mean, you hear the reason that I don't want my medication, my children on this powerful medication, then you have to explain it to them. But for the most part, maybe it's just because I'm doing this work, but I get these emails from the United States, you know, I need to put my kids on the medication, you know, New Zealand, and, you know, those kind of things. So maybe it's a bias sampling that I have. Yeah, I think so. I think that people are just, because they know I've been leading the project, they want to hear from me. I mean, I felt so bad because I had a nurse practitioner from Minneapolis wanting me to provide advice, and I had to back off, you know, try to introduce her to somebody else because she really wanted the help. But I know the medical legal setup in the States, you give advice, you're in trouble. So yeah, so I've really found people engage in trying to do the best. The other area, which, you know, we don't have time to talk about, is the use of CBD. You know, there's a lot of questions about CBD and all of those things. So yes.
I will ask this question. I'm not a medical professional, but I do get a lot of questions through the No FASD helpline around my child's been diagnosed with autism. Why should I bother seeking a diagnosis of FASD? And part of that's around stigma and a lot of the other issues. One of the things that I've begun to scratch the surface at and read about is that there are some potential medications that if they are prescribed to an individual with FASD, that can exacerbate symptoms for them because of their prenatal alcohol exposure. It can exacerbate or bring on symptoms of psychosis. Is that something that another reason why we need to get the diagnosis right, so that medications aren't going to cause necessarily more harm? Again, I'm not a clinician, I'm just trying to understand, I guess.
Yeah, no, thanks for asking that. I am not aware, to be honest with you, about any of the medications inducing psychosis. I mean, there's no doubt that the brain of the individual with FASD's composition is neurodiverse, and so the chances of having psychosis, and you had the question about psychosis, which continues to be a debated issue, is not unusual in somebody who already has deficits. But in terms of a medication actually inducing it, apart from cannabis, sorry? Oh no, causing more harm, like, I mean, that's not unusual, as you can imagine. You know, like if you have somebody who has methylphenidate, in a study that was done by, I think it's Coles, they found out that for those who actually benefited, it was working perfectly, but a number of them had increased hyperactivity. So that's the only one that I can point to. Now, there's all medications have side effects, so weight gain is a problem, you know, in things like risperidone. seizures is possible with people with bupropion. So, but I don't think it's uniquely different in people with FASD. Not from the reading of the literature. Yeah. Yes.
I just wanted to share, I saw my first psychotic 10-year-old 2 weeks ago on dexamphetamine. The paediatrician had increased their dex, and this child was quite psychotic. I've never seen a psychotic 10-year-old ever.
Right.
But the girl I was talking about with the FASD, I would say because she's got a vulnerable brain, because she's got FASD, she had a biological mother who had schizophrenia. Vulnerable brain, you're going to get more
absolutely
unusual responses to medication.
Really good point, Wendy. Yeah.
No, you're not going to get that in a study because people will look at FASD. Yeah. They won't look at someone with FASD with a parent with schizophrenia who's also got other, Yeah.
Yes.
Specific contraindications between these drugs that you might recommend. So if you've got your first line and then you move on to another cluster because you need to treat that as well.
Yeah. So specific to FASD, I would not say that there are specific contraindications apart from the study that I know. Together, absolutely, yeah. So really, like for all of us in psychiatry, anytime we give a medication that we know is going to increase the cytochrome P450 or decrease it, inhibit it, we are watchful about the dose, and that's why we give the advice: start low and go slowly, because then you may come across a reaction. That would be the main issue, but of course, like most things, there is the serotonin reaction that could happen if you give too much of the serotonin doses together, of the medication, especially on the mood regulation one. And then I mentioned the issue of bupropion and the possibility of seizures. So those would be the main things that I would worry about, that you're combining them. And for the most part, I think most psychiatrists will recognize that when you're combining, you want to make sure that these two work together and they're not going to accentuate or decrease. By the way, which is another thing, right? Like, I mean, if you have something that is like carbamazepine, which is eating up all the medication, then you may have to increase the dose. So that will be that interaction pharmacodynamically and pharmacokinetically that we need to be aware of. Yes, Millie.
You mentioned CBD. I've got a lad who's on risperidone but also quite addicted to cannabis. He smokes it. What would be the view of, that's polypharmacy in a sense. I can't get access to prescribed oil. So he's going to continue smoking the weed, he's going to continue being on his risperidone, he's going to continue being on his guanfacine. What would be, like, that's all over the place. What's the current view if they're smoking weed as well? And then talking about schizophrenia in particular, he's also got genetic abnormalities that lead him to schizophrenia, which means that there's a whole discussion about whether it's appropriate to prescribe CBD oil anyway, because there's a school of thought that that would bring on schizophrenia or some other mental illness, but the schizophrenia is the one that they keep quoting at us because of the genetic abnormality. So like, it's really complex. So and you've got a very small research base that you're basing this on. How much more research are you doing to indicate the validity of what you're proposing there?
Yeah, so as you can see, the role of CBD was only included as part of our adjunct, but THC definitely not advisable because that is the one that is responsible for psychosis. If I was a clinician, I'll be worried about the possibility of triggering a psychosis in somebody who is vulnerable. And I know we have just 5 minutes. I would love to tell you quickly about our app, and you can download it right now if you're interested. It's called Simply FASD, and I believe that QR code would be able to do it. We only ask that you help us with some data, because I'll show you now quickly. By the way, this is what it covers. It just asks you if you have a patient and what medications have they tried, what dose are you going to start based on the algorithm, what did you choose to start them on, then you report back on whether there's any benefit at all or any side effects. So everything is in the app just to be able to make life easier for you. I'm rushing because I want to kind of get to where we are with evaluation. So you can see that we try to evaluate whether the algorithm is working. As I mentioned, many people have downloaded it. I've talked in a Facebook group where many people find it helpful. Unfortunately, as you can see, parents are reporting on the benefits of the algorithm more than the physicians. It's actually for physicians to report, but the parents are more enthusiastic. So we really desire to have more physicians. Family, somebody was asking, what was it for? So as you can see, we have child psychiatrists, nurse, pediatrician, family doctors that are reporting. And what they are telling us is that there are additional diagnoses that they have, and these are the clusters that they found highest on. So as you can see, hyperactive actually, which is similar to what we have in the real sense. What really, for me, makes more sense is really what they're telling us that they're prescribing, and they're following according to the algorithm, and they're lastly indicating that 29% had substantial benefits, and then 47% had minimal benefits. So we are trying to get this data so that we can refine the algorithm and be able to at least make more recommendations in the coming years. But I think that suggestion on how do you monitor, how do we get more data, we are working on it. I had an excellent conversation with Dr. Elliott, whereby we may have to end up evaluating those who have been prescribed the medication to see how it aligns with the algorithm. Or we may have to end up going to parents and say, tell us your experience point blank and see if it's working or not. It's not the best, but it's been challenging getting physicians to the website. And we understand. I mean, physicians don't really have time for research. So that's the algorithm is available. You would hopefully get my email if you have any questions. I'm passionate about it. I can definitely provide the insight that I have in the area that I've done work on with this algorithm. Doug, I hope you're still there. I have 2 more minutes. Did you have any questions? The trainers that...
Thank you, Dr. Mela. I've been listening intently and taking notes. So, yeah, thank you for your presentation. It's been excellent. I've already downloaded the app while we've been talking.
Yeah, okay, that's great. Any other questions before we round up? No? Well,
No,
this... Okay, well, thank you. Okay, yes?
Sorry, could I encourage you to listen to the parents' carers? We see the doctor for prescriptions maybe once every 6 months. We don't always get the opportunity to tell them everything that's going on in the family because, they don't have time. We're in a position to know whether it's made an improvement or not on a particular behaviour in much more detail than probably a clinician could tell you. Okay. So please listen to parents, carers.
Well, as I mentioned, the whole algorithm started from carers and loved ones. So yeah, I mean, we made that choice out of frustration because we've been trying to evaluate for the last 3 years. But what you're saying, we have actually thought about it, and somebody suggested, well, why don't you think to the parents, let them tell you. If it's working, fine. If it's not, thank you. Well, thank you very much for spending your late afternoon here, but please reach out if you have any other questions or any information you want about the algorithm and other areas of FASD too. I really appreciate your time. Thank you.